Hello, my name is Sherry Martin. And this is
I'm presenting the Heart Failure
references.
Education Improvement Plan for our leadership class.
Very long.
A lot of research.
What we
Thank
had
you so much. Is a Centering for Heart Failure program that was initialized at our hospital. The program did not have the desired outcome due to advanced ages, multiple comorbidities, economic class, and lack of motivation, and also difficulty getting to and from appointments. The change that needed to occur is transitioning to a streamlined individual education beginning prior to discharge and continuing in the heart failure clinic. The lack of in-depth pre-discharge education for new onset heart failure patients results in increased readmission rates within 30 days of discharge and an increased death rate within 6 months. Heart failure is the primary diagnosis in greater than 1 million hospitalizations each year, and those hospitalized, the 30-day readmission rate is about 25%. Heart failure is responsible for approximately 12 to 15 million office visits yearly. Each year, 6.5 million hospital days yearly also. For the initial diagnosis of heart failure, there is a 5-year mortality rate of approximately 50%. The purpose of the project is to review and streamline heart failure education, to recommend a follow-up visit time schedule, and to educate to the staff that answers phone calls on the importance of the immediate contact with the provider for calls concerning heart failure patients with symptoms or questions. The components of heart failure education identified by Joint Commissions in 2010 are activity, medication management, weight monitoring, signs and symptoms recognition for worsening problems, and follow-up care. Self-care is defined as the degree in which a patient can process and understand basic health information and make health decisions. Patients benefit from better education as decreased readmission rates lead to decreased out-of-pocket expenses, and patients are able to maintain their independence at home and have better outcomes. After reviewing the education that is currently used and comparing it to the research that I collected, I found that the current heart failure education at Baptist Health is very good, and it's very hard to improve upon. It is guidelines, directives, and evidence-based. However, during the course of my research, I discovered many articles that discussed education for the low literacy population. And at this point, I switched the focus of the project to low literacy friendly education. And you'll see in my slides that there was so much information, I just kind of put it all together. So it's all oriented to pretty much low literacy patients. Patients with low literacy have higher emergency room visit rates, poor medication management skills which lead to lower medication compliance, and decreased capacity to recall information after clinic visits, higher rates of hospitalization and death rates, and increased 30-day readmission rates. For low literacy population, it is helpful to simplify oral education to clear basic language and avoid medical jargon. Studies have shown that incorporating pictorial instruction and printed materials increased patient comprehension by 27%. Printed handouts should be used to reinforce oral education when teaching these patients, but not as the primary form of education. It is helpful for the information to be presented in 3 to 5 chunks and to limit information on a need-to-know basis instead of nice-to-know. Do not ask the patient to weigh every morning, and this is just less than optimal teaching strategy. We have to tell them what to do so that it will fit into their daily routine. They're more likely to remember. An example you would use when you're speaking with a patient would be every morning when you get out of bed, you will pee, then weigh before you eat or drink anything. It's just simple, basic instruction. Education with low literacy patients should be relayed as must do and not do if it's okay if I want to do. Low literacy is defined as a reading level below the 5th grade or our elderly patients or patients above 65. Proper transition home starts from admission, from evaluation and education. Education consists of verbal, written, and visual information. Ideally, to evaluate caregiver and patient understanding, there should be demonstrations and teach-back sessions. Post-acute care follow-up visits should occur within 48 hours to 5 days post-discharge. For high-risk patients, which are patients that have had 2 heart failure admissions in the past 12 months, they would need an office visit or a home care visit, which we just instituted, within 48 hours of discharge. The moderate risk patient, which is 1 admission in 12 months for heart failure, would get a follow-up phone call within 48 hours and an office visit within 5 days. The objectives are to use evidence-based practice and published guidelines to implement the most current heart failure education to enhance patient participation through understanding of the disease process, utilization of medical therapies, recognition of symptoms and lifestyle changes to avoid hospitalization and to relieve symptoms and reduce clinical deterioration. Initiating a systematic time block scheduled for education sessions beginning prior to discharge and continuing indefinitely, and to promote early symptom reporting to the heart failure clinic and providers, to ensure timely follow-up on the same day within 24 hours. The staff will be educated and instructed on the importance of timely reporting to the proper personnel. The project plan is to implement pictorial written education material to supplement verbal education. I will streamline education where possible. I will recommend follow-up time schedules based on guidelines. The clinic staff will be educated on the importance of reporting patient questions and symptoms to the appropriate staff or provider. Every point in this slide has education listed. From 2005 to 2011, few changes were implemented in the treatment of heart failure and measures. The one major change was timing of education and more in-depth education on self-care. Education is the key to patient to recognize early symptoms and signs that lead to changes in clinical status. The understanding of care instructions associated with improved patient outcomes. Heart failure education of individual patients is a complex endeavor. The education must be tailored to each patient's individual learning. The education delivered should be guideline-directed and evidence-based. The research suggests that the patients learn more effectively without medical jargon. Low literacy patients learn better with basic information, and the more compliant if you tell them what to do instead of suggest what to do. It is in the best interest of our patients for everyone to be educated on the importance of relaying information from heart failure patients to the nurse or nurse practitioner or for the physician. The recommendations are rearranging the information presented in the current heart failure printed supplementation for the easiest, most complex order. Incorporating pictorial printed supplementation information. The addition of a sodium tracker where applicable that I found online. The clinic staff will be educated on the importance of relating phone calls with patient questions and symptoms, and importance of there being team members in the prevention of 30-day readmission rates and preventing the decline of heart failure in the patient. Follow-up visits for high-risk patients is an office visit or home visit within 48 hours of discharge. For moderate risk patients, a follow-up phone call within 48 hours and an office visit within 5 days. Follow-up visits for continuing education, medication, evaluation, and titration should be tailored to the individual patient because of their comprehension and compliance. I have learned a great deal while researching heart failure. I have learned that after being a nurse for 16 years, I did not know enough to be an effective teacher for heart failure. I'm confident now that I could teach heart failure education effectively. I discovered that Baptist Health heart failure education is very good. It is guidelines directed and evidence-based. While researching, I did switch the focus to low literacy patients. All of the current education is very good. However, I feel it could be altered or supplemented with the recommended pictorial education. While the printed information is good, nothing can take the place of the intense one-on-one education that Brenda Stevens, our nurse practitioner, provides for these heart failure patients. I did present recommendations for all of the goals set forth in this project as stated in the objectives in the project plan. Because patient attendance at the Centering for Heart Failure program was less than optimal, it was necessary to reevaluate education and follow-up scheduling. The two most important issues were identified during the evaluation data were tailoring education for low literacy patients and educating more appointment staff regarding the importance of relating phone calls from heart failure patients about symptoms and medication questions immediately. I feel the proposed strategies are important to educate patients, decrease the 30-day readmission rate, and help with the overall health of our patients, and decrease 6-month death rates, and hopefully the 5-year 50% death rate from the initial diagnosis of heart failure. I just wanted you to see the numbers, because you can say 1 million, but when you see it, with greater than 1 million hospitalizations and 6.5 million hospital days per year, a 25% 30-day readmission rate, 12 to 15 million yearly office visits, and a 50% 5-year mortality rate from the onset of diagnosis, we can conclude that involving the patient in their care and teaching them self-care is imperative for their health. We must teach them to go, which is ultimately self-care at home, and help them prevent clinical deterioration. And this is a list of my references. Very good. Very long. A lot of research. Thank you so much.